I think everyone else did, that this session will be recorded, so just to let everybody know. So yeah, we're going to talk today about bronchiolitis, and I'll also discuss a little bit about RSV. I am aware that probably most of you have attended other sessions in this webinar series, so I may be referencing some of the things that that have already been covered, either in our assessment class or the suctioning class. Okay, so to get started, sorry, I hope everyone can see the slides. We do have some webinar guidelines here. I think it's the same as the other sessions, so appreciate if you can just mute your speakers, but feel free to unmute when you have a question or use the chat. And then if we can have your attention to avoid multitasking, and obviously your participation is encouraged, we are going to have a little bit of an interactive case study at the end of this presentation. And I'll let Faiza just cover this part.
So we're just going to be launching a poll. We'd like to know a little more about you. So some of you who've been on our previous webinars, you can have a look at this. Today it looks like there's just the one question: what is your role? And then if you can place in the chat as well how many years of nursing experience you have. This will give us an idea of, oh, there you go. Sorry, just launching the poll now. Who's here today, and how many nurses, RTs, or leaders, or NPs, MTs we have in our webinar today. Great. Looks like we have about an 80% response rate, but mostly nurses here today. We have a few RTs and a few leaders in the organization, and one NP. Woohoo! And thank you for your responses in the chat as well.
Okay, great. Thank you, Faiza. We're going to dual screen. Sorry if I look like I'm looking away. Okay, there we go. So again, this purpose of this webinar is going to be just covering the foundational knowledge you need to care for pediatric patients with RSV and bronchiolitis, and as well to understand the recommended care and escalated intervention. So for sure you'll be parting with some hopefully not too new information, and if it's new, hopefully it'll be clear for you, but I will be pausing throughout the presentation for questions. So our objectives for today are to discuss and recognize the signs and symptoms, cause, risk factors, and course of disease, treatment, and prevention for RSV and bronchiolitis. We'll review some of the anatomical differences between our pediatric patients as well as adults, and how your care might differ. We're going to understand the appropriate nursing interventions for bronchiolitis and identify when to escalate concerns. I'm going to be introducing a bronchiolitis severity scoring tool, which we use, and I'll discuss a little bit more as to how to use and apply it into real life scenarios. And then at the end, just understanding the discharge criteria and any discharge teaching that's required for our patients. Okay, so RSV stands for respiratory syncytial virus, popular three-letter word right now going about in the news. So RSV itself is a common virus that infects the lungs and airways, causing flu-like symptoms. It often causes the common cold, but at times when it's more severe, it can cause bronchiolitis in young infants and toddlers. Most children who have RSV will just have a mild infection and not require any hospital attention, often can be cared for at home. Some of the signs and symptoms that are associated with RSV are cough, runny nose, fever, and a wheeze. Some of these infants and children who have it can develop a severe form of RSV, and that's when they need to come to the hospital and maybe also diagnosed with pneumonia or bronchiolitis. And again, today we're focusing on bronchiolitis. The risk factors for severe cases of RSV would be prematurity under 33 weeks of gestation, being under 6 months old during RSV season, which is right now. We're currently in RSV season, typically from November to April. additional risk factors would be being under 2 years of age, with lung conditions, congenital heart disease, Down syndrome, or otherwise immunocompromised. And the incubation period for RSV is usually about 2 to 8 days. In terms of treatment and prevention, there is an available prophylaxis for RSV. This is only reserved typically for infants who are at high risk. And so it's called palivizumab. It needs to be prescribed. And there is a specific eligibility criteria that's set by the ministry. So those of you who are providers will probably be a little more familiar with this. But this prophylaxis is administered once a month during RSV season. And the purpose of it is really just to provide some antibodies to reduce the chances of catching RSV. So it's not what we would deem like a vaccine. And it's only effective for 30 days, which is why the monthly need to come back in to receive your next prophylaxis dosing. Of course, part of the teaching that we provide would be how to prevent the spread of RSV. So right now, I'm hoping all of us are really good at and experts at doing this, but regular hand hygiene, for example, cleaning high contact surfaces, whether it's at home or even out in your schools or home workplaces, avoiding sick contacts, and then isolating from others when you're symptomatic. I've attached here a link here at the bottom. Those of you who aren't familiar with our About Kids Health, these are tip sheets that are created for different diagnoses and illnesses. So we do have one for RSV, so you can go ahead and, whether for yourself or for your patients, you can always access that and print it off and use it as a teaching tool for our families. So I'm going to pause here. Are there any questions regarding RSV? Nothing. Okay, Faisal, just stop me if there are any questions.
Yep, no questions so far.
Okay, great. Okay, so moving on to bronchiolitis. So again, we said that RSV can cause bronchiolitis. What is bronchiolitis, though? It's an acute inflammatory disease that affects our lower respiratory tract and often results in obstruction of our small airways. So I have a little picture here. Remember your bronchioles and then the alveoli or little sacs. So you can get inflammation there and mucus build up in those parts of your lung. It's a common lung infection caused by RSV or viruses like RSV. And I think the main point I want to remind everybody is bronchiolitis affects patients who are under 2 years of age. So at your hospitals, you shouldn't be admitting, like, for example, a 14-year-old with bronchiolitis. Everything that we're going to be talking about this point forward will be specifically for ages 2 years and under. And again, the diagnosis for bronchiolitis is going to be commonly seen during RSV season. So again, November to April. When we talk about signs and symptoms of bronchiolitis, as very similar to RSV, you're going to see some fever, runny nose, and cough, but you can also see other signs like fast, shallow breathing. You may see wheezing, retractions, nasal flaring, increased irritability, restlessness, or fatigue. And again, the increased irritability is not just, it's like unconsolable sort of irritability that we're talking about. So if you're able to console the infant and settle them, I wouldn't classify that as irritable. We're talking about, unconsolable irritability, and that can be a sign of difficulty breathing, for example. You may see that in infants. You may also see decreased oral intake as well as difficulty sleeping. For bronchiolitis, in the first few days, the cough may sound like dry, short, shallow, and weak, but as your patient starts to get better, they're going to try to start to clear this viral infection out of their lungs, and so you may get some coughing and mucus production as well. Similar to RSV, sorry, I'm just going to make sure everyone mutes their mics, please. Similar to RSV, your bronchiolitis may last for about 7 to 10 days. But in some cases, and this is a point that I think it's important to pass on to families, is that if your child has coughing or mild wheeze, that can actually last for several weeks even after the virus is gone. So you may have some lingering symptoms. I'm going to just review a little bit of respiratory assessment basics and some anatomy. Again, I think this was probably covered if you've attended the assessment class, but always doesn't hurt to review some of the basics. So in terms of when we go in to assess our pediatric patients, these are our children who are under 2 years of age. They're probably not going to enjoy being assessed. They're not going. They may be crying, upset, scared when they see somebody coming into the rooms. And so there's a couple of things, especially in terms of inspection, that you can hopefully try to achieve before approaching our patients. So things like assessing the size and shape of their chest, the way that their chest is moving, is it symmetrical, any respiratory effort, in terms of like even like retractions, trach tugging, for example. You may be able to assess from afar. You can definitely count their rest rate and hopefully obtain an oxygen saturation. So one of the tips and tricks I would suggest is you can engage your caregivers you can suggest to them, I'm going to come back soon. Can you remove their shirt, your patient's shirt? And if you can get a doorway assessment, you can try to capture a little bit of the inspection items before going into the patient's room. Sorry. Then we're going to auscultate. Upon auscultating, you're going to obviously listen for air entry, assessing for all lobes, remembering that there is a difference between the left and the right side lobe. So on the right side, you will get a right middle lobe. So there's upper, middle, and lower lobes, whereas on the left side, you only have an upper and lower lobe. We're going to listen also for any adventitious sounds. Do you hear grunting, stridor, crackles, wheezes, things like that? And then we're going to take all of this into perspective and remember that trending is also important. So we want to see how the patient has, what are their vitals, and how has your vitals and assessment been changing over time. We'll skip over to some airway differences. So these are the differences between the pediatric and adult airway. If you look at the picture there, you can see that in the infant especially, there are some things that may make an infant more prone to obstruction or airway narrowing. You can look at the shape of their, they have like almost like a cone-shaped airway, a little bit wider at the top where their nose is, and then narrows down to where the larynx is. And they also have a floppier epiglottis. Their tongues are also much larger in comparison to the adults. They also have shorter and softer tracheas. And infants, definitely, we're going to be emphasizing this throughout our presentation, is the need to suction their nose. So infants are mouth breathers. And so anytime there's an obstruction in nose breathers, and so anytime they're very reliant on breathing through their nose. So if they have any kind of obstruction, whether through like mucus or secretions, it's important to keep that airway patent. So we highly recommend you doing some tip suctioning for their nose, or nasopharyngeal suctioning as needed. Babies and young children also, their diaphragms are, to breathe, they rely on a lot of their abdominal muscles to pull their diaphragm down on inspiration. And so you're going to see some belly breathing, which is not a common thing for adults, but belly breathing is a normal assessment finding for our younger children. I've also listed there some red flags for respiratory distress. This is just in general in terms of a respiratory assessment. So you might see tachypnea, like changes in the way of the breathing, retractions that we've already covered. Head bobbing, for example, is something that you may see in infants. So head bobbing, first time I remember seeing it, it looks kind of cute from afar because your little baby is just doing this, but it's actually a sign of respiratory distress. And so you should be concerned if you do see head bobbing from a child, and that will probably also be associated with other signs such as like nasal flaring. They may be trach tugging at the same time, or even some associated desaturations. You may also see some grunting, prolonged expiratory phase, diminished airway sounds. And then if you're seeing any of the late signs of respiratory distress, such as cyanosis, or your patient starts to turn dusky, inaudible air entry, or apnea, these are all signs that you should be calling for help immediately. Okay, I don't think, if there's no questions, I'll keep going. So for bronchiolitis, again, there are some risk factors that are associated with severe cases of bronchiolitis. These are very similar to what we've already talked about for RSV, but being very young, so under 3 months of age, if the child lives in a house with smokers, if the child has asthma or any other chronic lung diseases or problems, if they're premature, typically under 32 weeks gestation, if they have any cardiopulmonary disease, immunocompromised, or are medically complex or have severe comorbidities. These are all things that can put your child or put the child at risk for severe bronchiolitis. Some of the, why do we have bronchiolitis, or why is RSV being passed around? Again, this is kind of basic infection concepts, but this is a droplet. It's transmitted via droplets, and so the infected person could have either coughed or sneezed, and someone else is then touching an infected object and then touching their face as well. So we do at the hospital, whether at the hospital or at home, try to prevent the spread, whether you're talking about masking, hand hygiene, or cleaning surfaces often. Okay, so we're going to get into the interventions. One of the main points, again, I want to reemphasize throughout this presentation is going to be that clinical course is generally not changed by any aggressive evaluations, interventions, the use of antibiotics, or other therapies. So for bronchiolitis care, we're going to talk about it, but there are a lot of sort of basic nursing interventions that we would use, and as opposed to prescribing certain medications or doing something in a more aggressive therapy. So we'll definitely review that. A lot of studies have already shown that there is no need for these other therapies because it's basically unnecessary. We'll talk about it again, and so I'm not going to go into too much depth right now, but a lot of studies have already shown that there really isn't too much aside from managing symptoms. The goals of interventions are always going to be to obviously decrease the use of unnecessary diagnostic studies, decreasing the use of medications, providing guidance on appropriate respiratory therapy. We want to improve the rate of appropriate admissions, apply appropriate monitoring, and then decreasing the length of stay. So these are the things that we want to keep in mind when admitting patients and when providing care for our bronchiolitic patients. In hospital, the things that you want to either initiate or continue for treating our patients with bronchiolitis would be to put them on droplet contact precautions or follow your local institution's infection prevention and control recommendations. You're going to use minimum handling strategies. So, clustering your care. We want to minimize any sort of, if we're going to bug our patients, we want to try to get that all over and done with, because we want them to be able to rest, and we want to ensure that they're comfortable. So minimizing that time where we may agitate our patients is important. You can also dim the lights and just limit overall stimulation. We want to continue to monitor our patients' vitals, typically every 4 hours or as needed if their vitals begin to change or are worsening. And then you can transition over to spot saturation monitoring every 4 to 6 hours once they have achieved stable vitals. With that comes obviously assessment and documentation of their vitals and their work of breathing. We also want to assess for fever and treat with antipyretics as indicated. Repositioning and nasal suction, again, the reason why we would want to encourage nasal suctioning is, again, because our infants and younger children under the age of 2 tend to may depend on breathing through their nose. So we want to keep those nasal passages patent. And then repositioning, if you think about your lung anatomy, a lot of times there is mucus buildup, like we said. Why one of the symptoms of bronchiolitis is mucus buildup, and so repositioning them into an upright position will help their overall alveoli expand, and any secretions can hopefully drain down to the bottom. We want to be able to maximize their surface area for air exchange as well in their lungs. So try repositioning them into an upright position. You can also apply oxygen as needed via low flow nasal cannula. We want to keep our saturations above 90% when awake and above 88% when asleep. You may have seen different parameters ordered perhaps for your patients. The 90% and the 80% is specific to bronchiolitis and for the age group of 2 and under. You may consider heated high flow via nasal cannula for severe cases of bronchiolitis. If you're going to go that route, the recommendation is starting at 2 liters per minute per kilo for patients weighing under 10 to 12 kilos. You can also attempt to wean the oxygen every 12 hours, obviously as tolerated, and then you can try an initial wean and then continue to wean every 4 hours afterwards. We want to also maintain hydration. So considering a TFI of 80 to 100% maintenance is something you want to do while in hospital, unless the patient is hypovolemic. Unless if the patient is not significantly hypovolemic. With hydration also comes nutrition. So you want to be able to maintain them on their feeds, whether they're breastfeeding, bottle feeding. An infant, for example, may not be able to tolerate the regular length of feeds, and so offering more frequent feeds at lower volumes can be helpful for them. At times, an NG or OG tube may be inserted. That's more so if the patient is experiencing respiratory distress of moderate to severe levels of respiratory distress, and to help maintain their hydration, you wouldn't want to, for example, offer a bottle for a patient who's already having trouble breathing, just because of aspiration risks. Sometimes an IV may be started, and you would run D5.9 normal saline as needed as an alternative to an NG feed. But again, that's up to the clinician and family discretion whether an IV would be recommended. Okay.
Before you move on, there was a question about whether bronchiolitis is caused by viruses other than RSV. So I did make a comment that yes, it can be caused by other viruses, but RSV is typically the most common one, especially at this season from November till about April. So it is a fairly long season with the peak sort of happening now in December. And then another question about, are kids allowed to eat when they are on heated high flow nasal cannula? And I'm able to answer that. So yes, they are, as long as they're stable and they're high flow. So they're stable on high flow and they're stable enough to eat, they can certainly eat on that. If they need, let's say, an aerosolized medication for any reason, then we would take the Airvo off and provide that, and then replace the nasal cannulas for heated high flow. And we do talk about that in our oxygen and Airvo webinar as well. So if you're interested in attending that, we do have a few more coming up. And is there a certain cutoff in terms of FiO2 or liters per minute? And Tracy, you'll have to be a little more specific on that. Are you talking about in terms of oxygen in general, like nasal prongs in general, or are you talking about cutoffs for oxygen levels for heated high flow prior to escalation? So I'll let you answer that in the chat. And then Steve, yeah, I'll put the link up again for the slides as well. And then another question, just to clarify, once oxygen is applied, is the recommendation to attempt to wean only every 12 hours in general, and if not tolerated, attempt later?
If you're asking about like the weaning, I guess I think the question is more if they don't tolerate the at 12 hour, like when you try to initially wean a patient, if they're not tolerating, you just leave them as is, leave them back at the same setting or increase the settings if needed. And then you can try again. You can try maybe giving them a couple hours or another hour. It's basic. You need to kind of assess your patient to see, you know, whether it's appropriate to wean. And we'll talk about a couple other like vital signs and assessments later on with the bronchiolitis severity scoring tool that will help, but more so emphasizing also intervention. So have you done everything in your intervention bundle care to maximize their oxygenation? And if so, Perhaps if you've done all those things and your patient's still not maintaining saturations or still needs oxygen therapy, that's probably not an appropriate time to wean.
So I was just looking at the attempt oxygen wean every 12 hours. So is that like a minimum? Is that what that means? You should attempt to wean at least every 12 hours, or is it meaning if they don't tolerate the wean after, then you should delay for 12 more hours?
That's the initial wean. That's the initial wean. So place them on and then try to wean them after 12 hours initially. And then if they don't tolerate, then keep reassessing and attempt later. Usually after every 4 hours is usually the recommendation. Does that answer your question, Katie?
Yes, thank you.
Yeah. Okay. And then in terms of, I think there was another question for you, Noelle. Are infants able to breastfeed or bottle feed while on Airvo? And since it is not solid food, is there higher risk for aspiration versus solids?
Mm-hmm. So again, with the whole maintain hydration versus providing them with oxygen, you can breastfeed while on Airvo. But again, if your patient is if they are requiring a lot of suctioning or just are working really hard, I would say just to keep them on Airvo for a bit and then have the conversation with your team whether or not like an NG or an IV is necessary. If it's for like, maybe the baby just needs a break. So offering those like smaller volumes, more frequent feeds that's kind of like where that purpose of offering frequent feeds comes in handy, is that you may only be able to breastfeed for maybe 5 minutes and then give them a break because they're not going to be able to be at the breast for 30 minutes like they normally would.
Okay, and I think, yeah, that's it for now. Thank you.
Thank you. Okay. Okay, so I'm going to introduce this bronchiolitis severity scoring tool. This is a tool that was introduced to us as sick kids, less so to kind of determine the severity of bronchiolitis. We actually implemented this tool to help not only the RN, but also the RT and the medical team decide if it was appropriate to start heat to high flow via nasal cannula for our bronchiolitis patients. So with this tool, it's not just a determinative, you're gonna score the patient and leave it at that. Really, the tool was emphasized to implement, score the tool, provide the necessary interventions, and then re-score the patient after you've provided interventions to see what that change was. If there was a change, has the patient's score worsened? And if so, that may be an indication to start heat to high flow. That's kind of the purpose of the tool that we've been using here at Sick Kids. But I do find value that for nurses who may not be very familiar with bronchiolitis, this at least will help you kind of objectively quantify, the severity of bronchiolitis. But just keep in mind that our purpose is to also implement interventions and see whether those interventions were effective. So going through this tool itself, there's based on 3 criteria: the rest rate, which is broken down into age groups here, and then the associated scores. You have retraction signs, so starting off with no retractions, just intercostal, then intercostal with subcostal or substernal indrawing, and then most severe being intercostal, subcostal with nasal flaring or chest wall indrawing. And then you have wheezing, so starting off with no wheezing at all, expiratory, inspiratory, and expiratory, and then the last one, most severe, being audible wheezing. So this is something that, with the scoring, you can get a score anywhere from 0 to 9, and I will talk about what those numbers mean. So to score mild would be anywhere from 0 to 3, a moderate score would be 4 to 6, and then a severe score would be 7 to 9. So again, I'm going to emphasize that the score itself is not as important as guiding your interventions and whether the interventions were effective. So if your patient does score a mild to moderate based on your assessment and findings, do the bronchiolitis bundle interventions, which are listed there in blue. So have you considered, or is it necessary to provide antipyretics for your patient? Are they febrile? Assessing hydration. So can you encourage oral feeds if they haven't been feeding well? And again, that's only if safe. So if it's not safe, you can talk about IV or NG, OG feeding. Have you repositioned and suctioned the nasal passages of the patient? We talk about tip suctioning for a lot of our infants, but sometimes it may also be necessary to provide nasopharyngeal suctioning, so going a little bit deeper. Do you need to apply low flow oxygen for your patient and in order to maintain their saturations above 80% when asleep and 90% when awake? We talk about bundling our care as well as minimizing the stimulation. So, you know, you want to actually physically bundle your child and then dim the lights. Clustering care is helpful. So we want to emphasize doing these things in this bundle of interventions. Give your patient about 15 to 30 minutes afterwards. So let them settle for a little bit, see if these interventions are actually effective, and then go back in and rescore them. If the patient is stable or their score kind of remains in the mild to moderate, then you would just continue to assess your patient and document the bronchiolitis severity score again every 2 to 4 hours. However, if your patient worsens and is now into a severe category, that will be a cue for you to call your respiratory therapist and then consider initiating heat to high flow. Again, this should be a discussion with the RT in consideration, of course.
We have 2 more questions for you, Noelle.
Yeah.
So is the scoring tool built into Epic?
Yeah, so that's a good question. For us, we had to manually, somebody in the hospital had to enter it for us. So fortunately for our nurses, it flows seamlessly. It shows up for all of our patients admitted for bronchiolitis in the pediatric medicine department as well as emergency. But at your local institution, whether you want to do a paper format or if there's a way to include it into electronic documentation, that would probably be helpful.
Okay, and then there's another question. Would there be a general interpretation on the score or just comparison for post-treatment and communication tool? And I think you've kind of answered that in your reassessment after 15 to 30 minutes, but I'll let you answer.
Yeah. So when we were implementing this tool, it was for autistic kids, it was affiliated with a study, more so to decrease the use of heat to high flow for patients with bronchiolitis, unnecessary use of heat to high flow. The tool itself is actually like a not validated tool in terms of like a diagnosis. Like the purpose of the tool is not really to say, oh, you have mild bronchiolitis or you have moderate bronchiolitis. It's really just a cue to help guide the interventions and to determine whether or not in severe cases of bronchiolitis, whether heat to high flow is necessary. So if you are going to use the tool, please do, the numbers mean less as opposed to intervening and providing the bundle of care that we just talked about, and then going back in to reassess if that bundle was actually, if your interventions were actually effective. If that's clear. With a severe score of 7 to 9, again, it's going to be calling your RT, continue to document with the bronchiolitis bundle, using that as a guide, and then considering heat high flow. Okay, we talked about interventions. We focused a lot on the bundle, but there are a couple of things. Remember, we talked about the aggressive therapies and like treatments that are not necessary. So some of those things that are not recommended include chest x-rays. Unless your patient unless there's like an alternate diagnosis being considered or patient is considered to be transferred to ICU, there's no need for chest x-rays. In terms of blood work, it's again not necessary unless you're concerned for sepsis or any other potential respiratory failure. There's no need to do any NP swabs to test for respiratory multiplex PCR testing, nor is there a need to do any rapid flu tests. If we're talking about therapies or medications for bronchiolitis, it is not beneficial or it hasn't been shown to be beneficial in studies to provide any nebulized epinephrine, hypertonic saline, salbutamol, corticosteroids. Antibiotics are not needed, especially because this is there's a viral cost to this. And then pulmonary physiotherapy or coolness therapies are also not recommended.
So there is a question in the chat. Are bronchodilators recommended?
Yep, so bronchodilator would be like Ventolin, I'm assuming you're thinking. So as for studies, it's not recommended. I think that we talked about this before in a previous webinar, but providing you could try your team may decide to trial maybe 1 dose of Ventolin, but find that it's not effective afterwards. Bronchiolitis itself, I guess, doesn't really respond to bronchodilators.
I do want to add, though, that so if you guys are escalating, you're sort of maxed out and you're escalating care, you have to call a critical. They may sort of advise you on, ensuring that, that you've tried certain things. So they might, just to bring some reassurance, they may say do a cap gas if you're worried about the patient, do an x-ray, or they may even ask you whether you have tried bronchiolitis or recommend it, just as a, if there's wheezing due to the inflammation and stuff.
Thanks, Tyler. Okay, and Faiza kind of, I guess, sort of touch on this, but if you're escalating, so when to escalate concern or care, again, if you are considering based on the scoring, remember we're doing pre and post interventions. If your patient is, not responding to the interventions you provided, you've suctioned, you've repositioned them, or their score is now changed to severe, that is an indication for you to consult your respiratory therapist to consider HEDA high flow. And if your patient is already on HEDA high flow and still having increased respiratory needs, then please do involve your medical team and contact your critical care response team as per your institution, because ICU admission may be something that's considered at that point. Okay. We can do a case study. So there's a case study here, and I think it'd be great to apply the bronchiolitis severity tool that we just talked about. So we have Olivia here, who is a previously healthy 13-month-old girl. She was admitted overnight with RSV bronchiolitis. She was occasionally tachycardic, tachypnic, and febrile overnight, and her oxygen saturations were 97 to 98% on 1 liter of oxygen via nasal prongs. She also had an intermittent cough. Unfortunately, she didn't really sleep too well and also didn't breastfeed well overnight. She did receive 1 dose of Tylenol PRN 4 hours ago. So that's our case scenario. You're coming into the room right now in the morning to provide a set of vitals and assessments. She's Olivia. You find her restlessly sleeping in her crib, but she wakes up when you bug her or when you touch her. I've listed her vitals there. So heart rate of 164, her BP is 86/50. She has a temp of 38.5 rectal. Her rest rates are 42, and she's currently satting 90% on the same 1 liter of oxygen via nasal prongs. She has moderate work of breathing, shows intercostal and subcostal indrawing, as well as an expiratory wheeze, and is nasally congested. So based on all the kind of information that we've just shared, take a look. The tool is over there on the right. Let's first just determine what her bronchiolitis severity score is, and then think about what are your concerns and what interventions might you provide. So feel free to respond in the chat, or you can just speak out loud. Okay, I see some entries in the chat regarding our severity score. So I'm just going to close this for a second. There you go. Okay, so if we take a look at our bronchiolitis severity score, you can see that the patient has a total score of 5. Based on her age, she's 13 months old. She's getting a score of 2 for rest rate. She also has intercostal and subcostal indrawing, so we're giving her another score of 2, and then she has expiratory wheeze. So total score of 5. With a score of 5, that would be deemed moderate severity. Does anyone remember what we might want to do, or what are we concerned about, and how would we intervene? Katie says you could consider starting an IV for hydration. Yep, you can definitely consider IV start for hydration. However, even before starting that IV, I would definitely consider offering her another feed. So getting mom to try to breastfeed again, and supporting her with offering the breast a little bit more frequently, and not expecting Olivia to be able to feed for as long as she normally would. So I'm just trying to skim through the chat here. Some of you have commented on Tylenol. So Olivia is febrile. She has a temp of 38.5. So offering antipyretics is definitely helpful. So a couple of you've also talked about nasal suctioning. So repositioning and suctioning are very basic, sort of like nursing things that we can do as soon as we go in the room. Definitely try to do that. Again, putting her in an upright position for and then suctioning would help. Whether it's nasal just tip, you can try that. If after tip suctioning you're still hearing some gurgling, or it sounds a little bit deeper in the airway, you can go ahead and try nasopharyngeal suctioning. In terms of oxygen, we can also try after those interventions. If she's still not recovering, her saturations aren't coming up, you can then try to increase oxygen. If we're going to increase oxygen, I don't see it specifically here in their chat, but what would you increase your oxygen to? Yep, so Sylvia is suggesting 1.5 liters. Katie says max 2 liters nasal prongs. I think that would be appropriate to try increasing your oxygen, but really the first steps is always going to be suctioning and repositioning first. Those are just basic things. And then going up on her oxygen to 2 liters, seeing if she seeing if if she responds, and if not, we can then consider other interventions, potentially requiring key to high flow, but that's a later conversation. I think we got, I think I captured everything here. So great. We did cover everything in our bundle that we discussed, except for maybe one other thing is just to cluster your care. So if you're going to go in and provide all these interventions, try to do them all at once. If you need to bundle Olivia afterwards, that's actually on the next slide here, but we can bundle Olivia, pass her back to mom, and encourage mom to try breastfeeding again. We've provided her with Tylenol and seeing if that works. We're gonna let Olivia settle for about 15 to 30 minutes, and then we're gonna go back into the room to reassess her. So our scenario continues. You return 30 minutes to complete your reassessment, and Olivia is still crying and appears to be in respiratory distress. Her vitals now are a heart rate of 176. Her BP's gone up to 92 or 56. Her temps come down to 37.6 rectal. She's respiring 64 and has an oxygen saturation of 92% on 2 liters of oxygen via nasal prongs. But she's showing severe work of breathing with intercostal and subcostal indrawing and nasal flaring. She has head bobbing, inspiratory and expiratory wheeze, and a lot of nasal secretions and coughing. So same thing, let's score her with the bronchiolitis severity tool on the side. And what are your new concerns, and how are you going to intervene this time? Okay. Great, I'm seeing some really good responses. People I think, have all agreed that the score is 8. So let me just switch our slides over here. Okay, so this time, we circled our new score. So again, now she's getting a score of 3 for her respirations. She's scoring 3 for retraction signs, and then a 2 for inspiratory and expiratory wheeze. So total of 8, which is correct. And I think whoever has participated in responding, in terms of your interventions, identifying that there is some respiratory distress or failure occurring, to consider key to high flow. So anytime you're considering heat to high flow, please do call your RT. If your patient, she's holding steady at 92, but if let's say she desats in the next little bit, you may consider providing her a non-rebreather mask just to support her while help is coming. And then let's see, what else is there? IV and suctioning. Yep. One other thing is to always, you can go back to trying again all the bundle elements. So do you need to go back and try repositioning her into a different position? You may try suctioning her again. She has a lot of increased secretion since you were last in the room. So go ahead and try suctioning. Make her comfortable as best you can. And then calling for help, calling for the RT to come into the room. I think we discussed all these points. Yep. Definitely important to continue to monitor your patient and see if seeing how they're doing, and then also supporting our caregiver and the patient. So mom may be distressed, kind of looking at Olivia right now. So just explain to mom what's going on, and you know, the purpose of why you're calling your RT or medical team into the room at that point. Great work, everyone. Thank you for participating. Let me see, what else do we have here? Oh, I see. Yeah, I see Bonnie's question here.
Okay, yeah.
Yeah, thank you. Would you let a charge nurse or physician know about the change in status for situational awareness or not yet? Here I would definitely, any change, whenever you're considering calling an RT, I would always consider also, not consider, but I would definitely inform the charge nurse as well as the medical team. Medical team will most likely be involved in the decision-making for initiating heat to high flow. But again, the heat to high flow consideration, you'll want to have an RT involved. Sylvia is also commenting that heat to high flow requires an order. So yes, I don't know if that varies in any other institution, but heat to high flow should require an order. And so they should be, your medical team should be involved. Maxine's asking, would you suction the patient until heat to high flow is started? Yeah, so suctioning is really just for secretion management. So you are going to want to, if there's, you know, there's snotty congested, do try suctioning. You can, again, try tip suctioning first. And if that's not effective, you can try going deeper. So nasopharyngeal suction. If your patient starts to desaturate, then you can go ahead and provide extra oxygen, additional oxygen with a non-rebreather mask if necessary. Yeah, I think that's pretty good. I don't know if there's any other questions coming in, but feel free to stop. We're almost at the end here. Great, so we worked through our scenario and hopefully Olivia is healthy and ready to go home. In terms of discharge criteria, we want to look at the respiratory status. So the patient should hopefully be improved by now. Tachypnea and work of breathing have also improved, so they should be breathing quite comfortably with their maintaining oxygen saturations on room air within the same parameters. So above 88% when asleep and above 90% when awake. We want to make sure that the child is able to orally feed, whether it's breastfeeding or bottle feeding or just drinking by mouth, just to prevent dehydration. And then we want to make sure that the parent or guardian can provide this care at home. So supporting them, reminding them about how to prevent bronchiolitis and RSV, the importance of maintaining hydration at home, treating with antipyretics, and then even, you know, they may see coughing or wheezing over the next couple of weeks when discharged home. We can also give them additional resources. So we talked about the Kids Health tip sheet. So there's one for RSV and there's also one available for bronchiolitis. So you can go ahead and print that and share that. They may also require some primary care provider follow-up. So just ensuring that they know who to contact or when to go see their primary care provider. In terms of treating bronchiolitis at home, only severe cases, well, typically severe cases are when they would come to hospital, but most cases can also be treated at home. And so we want to enforce this exact sort of the same things that we would do in the bundle. So positioning your patient or child upright and to improve breathing. So if they're lying down in bed coughing, we want to sit them up, make them comfortable. Any nasal congestion can be cleared with using saline nose drops, or that, I don't know what it's called at home, but there's a suction device that they would use like a straw to suck up. I know some parents use that to help with nasal congestion and suctioning. We want to monitor for signs of dehydration, and with that, we can continue to offer frequent, smaller volumes of hydration, encouraging breastfeeding and formula feeding. For older kids, you can offer water or diluted apple juice, but making sure that we do continue to offer that hydration. We want to reduce any allergens that are in the air. If they're exposed to tobacco smoke at home, making sure that they are avoiding those environments if possible. We don't want to be giving our patients under 6 years old any cough medications. And then enforcing preventative practice, so hand hygiene, eliminating smoke exposure like we talked about, and any contagious sources. And then when to seek medical attention. Again, I think this is something that's important to enforce with our families. So they should come back to the closest emergency department if they see signs of fast breathing, having difficulty breathing, any cyanosis, signs of dehydration. So you're being dry, having sunken eyes, or decreased urine output. Worsening general appearance. So are they all of a sudden more sleepy, more lethargic, just overall decreased energy levels? Are they irritable? So again, that's irritable and unable to console. And then any infants that are having trouble feeding or drinking. At the bottom there is just a hyperlink to our bronchiolitis about kids health tube sheet that I was talking about. And before I skip to summary, I don't think there's any ongoing questions. So our summary page is really just to recap the main points when caring for patients with bronchiolitis. This is a common lung infection that does affect our lower respiratory tract, caused by the virus, such as RSV. This mainly affects children under 2 years of age during RSV season, which is November to April. It's not recommended to provide aggressive interventions, use of antibiotics or other therapies, but instead clinical management of symptoms would include things like antipyretics, assessing hydration and encouraging oral feeds, repositioning and suctioning your patient, applying low flow nasal prongs to maintain saturations above 88% when asleep and above 90% when awake. You want to handle the patient as minimal as possible, so clustering your care, dimming the lights, and then always consulting an RT, and you can utilize the bronchiolitis severity scoring tool pre and post interventions when considering heat to high flow. Okay, so I will pause here. I don't know if anybody has any additional questions. I think we're good with the questions. Again, the slide deck I think has already been shared with you. I don't know if there's any additional, I think there's an additional information package that may be sent out. But on my slide deck, I also included a couple of additional resources. I just listed some differential diagnoses for wheezing in case that may be something that you may be considering at the bedside. And then I've also included what we use here at SickKids, the heat to high flow initiation pathway for bronchiolitis. So when would we apply heat to high flow, as well as the heat to high flow chart for the flow rates based on weight.
I think Hillary was saying that she did ask a question, but it went to one of us directly, and I don't think I got it, so it must have been you, Noelle. Hillary, if you want to ask your question, I apologize, or just repost your question, that would be great. And then, yeah, if you can do the survey, that would be great. It should just take a minute or two. And then the links that we had posted for the slides, you'll see other resources there as well, which is the Canadian the CPS bronchiolitis recommendations, and then our policy and procedure, CPG, on management of bronchiolitis in infants, as Noelle had mentioned.
Hi, this is Hillary.
Okay.
Hi, my message is a bit long and I'm very technologically impaired, so this is probably quick. My question is more around the O2. Like if we're happy to see RSV bronchiolitics sit a little bit lower in their SATs, like 88 while they're asleep, and low 90s while they're awake, do we leave the O2 just to kind of maintain that? Like I know normally we're not comfortable with seeing that. You want to see them up like, you know, super high. So do we continue on our flow or O2 to get them up into the high 90s, or do we leave our O2 lower just to maintain that kind of lower end of their SATs?
So initially, I mean, you could try to, you know, when you're initiating things and just try to optimize them. If they come in acutely, you can try to get, you know, sort of the mid to high SATs, or you may get them automatically, you know, when you're doing all these interventions. But then, you know, you can wean down fairly quickly to sort of, you know, the recommendation. So they don't need to be super high, because you're just doing maintenance at that point. And you know they're sick, and you know they have a lot of secretions, and you know they're going to be sitting on the lower end of normal, likely. I don't know if you have anything else to add, Noel.
Oh, that's great. Thank you, President.
The survey link, Anna, is on the screen, but we can send that again if you'd like. Yeah.
I also see, I think it's Tatiana's question regarding how long would a child be considered contagious for after onset of symptoms. With RSV, the incubation period is like 2 to 8 days. So how long are they contagious afterwards? I think what we're enforcing, if they're symptomatic, they can potentially be spreading their germs. So until they're not symptomatic, I would say is not when they're not no longer contagious. Awesome. Thank you everyone for attending. Please do fill the online evaluation, where we always welcome your feedback and happy to incorporate your feedback into the next webinar that we provide. And if you are able to attend the other webinars in our series, that would be amazing. But thank you so much for your time this afternoon. And we'll see you around soon. Good luck with caring for all these RSV bronchiolitic babies out there.
Thank you, everyone. Have a great day.